I hope you can see my screen, and now in screen show mode. So as the moderator of the session, we have Dr. Rishikesh Thakre. All of you all know what a wonderful speaker and what a wonderful person Dr. Rishikesh is. He is the consultant neonatologist and director in Neo Clinic in Hospital Aurangabad. He's one of the first few people who passed out from Sion Hospital in Mumbai. And he's involved in a lot of academic activities under different banners, whether it's NNF, whether it's IAP, whether it's IAP Neocon, and he keeps himself and others busy in bringing out books and guidelines. His field of interest is teaching, and you will hear from him to see what a great teacher and a neonatologist is. Welcome, Dr. Rishikesh. Thank you very much for not even, taking a second to say yes to moderate this panel. If you don't mind, I would really like to have the privilege of introducing our panelist, that is Dr. Subhadra Jalali. Madam is the force behind ROP in India, I would say. I think you have dedicated your life for the newborn eye. And whenever we talk anything to do with eyes and saving eyes, you're always there. You have, you're the network director and quality director in LV Prasad Institute in Hyderabad. And you're also the director of the New Eye Health Alliance for the Newborn Eyes. You have been the leader in Retinopathy of Prematurity National Task Force for the Government of India, and also have been the expert advisor for various other governments with huge number of presentations, publications, and awards. You are extremely passionate about eye screening, but you also have other interests, whether it is cultures, cuisines, and also enjoy reading, dancing, and music. You will learn about why we wanted Madam here. And again, Madam, despite your busy schedule, you are with us today. Thank you very much. And I'm sure all of us would enjoy listening to you. The second panelist is Dr. Deepak Chawla. Dr. Deepak Chawla is a very quiet person. He is known to the world through his work, whether it is research, whether it is guidelines. Dr. Deepak Chawla is always in the forefront. All the CPG guidelines that NNF is bringing about is all his hard work. Thank you, Dr. Deepak Chawla, for making time for this meeting today. Dr. Deepak Chawla is professor and head of the Department of Neonatology in Government Medical College, Chandigarh. The third panelist here is another quiet person who has been quietly taking care of babies in East India. And as you will see, we have our pearls from different parts of India, north, south, east, and west. Dr. Suchandra Mukherjee is the professor and head of neonatology in one of the largest institutes in India, that is in IPG MER, Calcutta. And she is, again, passionate about not only the newborn eye, but the newborn brain. She has done a neonatology, neurology training from the UK. And way back, I think more than 15 years ago, she has been instrumental in setting up the follow-up clinics in IPG MER, which is something that all of us, when we have the opportunity, must go and see. Thank you, Suchandra Mukherjee, for being here. The third person here is Dr. Lingaraj Pradhan. Dr. Lingaraj Pradhan is a senior consultant in Capital Hospital in Bhubaneswar. Sir has several publications to his credit and has been a force in not only Orissa NNF, but also on the national front. And all of you all will realize that all our panelists have original research work and publications in ROP, particularly from the SNCUs. Thank you, sir, for making time to be here. And last but not the least, we have our very own Dr. Sandeep Kada, who is our office bearer from IAP NeoChap. Dr. Sandeep, thank you very much for being here. Dr. Sandeep is consultant neonatologist. He's been my colleague in, I would say, in crime, I would say, in while doing DM in Mumbai. And he is currently in KM Hospital and MGM Hospital, Pune. Thank you very much. And now I hand over to Dr. Rishikesh Thakre to take over the panel.
Okay. Thank you very much, Suman, Naveen, and the IIP Neonatology chapter for this opportunity. It is indeed a pleasure and privilege to have with us faculty rich in experience and expertise in the field of ROP. The objective of our panel discussion would be to lay down and understand what are the best clinical practices which are evidence-based, which will help us reduce or eliminate the incidence and severity of retinopathy of prematurity. Well, India shares a significant burden when it comes to global health, when it comes to births, low birth weight population, or for that matter, the preterm population. And in our urge to make these small babies survive, unknowingly, many of them end up with a problem. And though we may give them right to life, we take away their right to sight simply because many of them go on to develop retinopathy of prematurity related blindness. And it is estimated that the ROP population in India is likely to overnumber the number of babies across the globe with ROP. So with this background about the burden that India faces, we are indeed fortunate to have with us Madam Jalali, who has been a tall figure in the field of ROP, and Madam has been instrumental in formulating the guidelines. Though we heard from Dr. Vinekar, let me just from those who joined late, Madam, could you share how do you identify the population at risk for ROP? Simply because when we look at the guidelines across the countries or within the country, we find varying gestation and birth weight cutoffs that are being looked at. Over to you, madam.
So the guidelines have been country specific. The reason for this is that initially we all used American Academy guidelines or UK guidelines. And when I started my work here in 98, I thought that, I just wanted to learn more about the disease because I had no training initially. I trained for 3 months in USA. Then I thought that, okay, let me see all the babies of all types and try to even learn how to look at a baby's retina practice. So then I slowly realized that almost 15 to 20% babies were having severe ROP, which were outside the American and UK guidelines. And then we published this data along with the USA and UK team to say, and then this was published from all over the world also, that in developing countries, because of differences in the mother's health and the neonatal care, which may not be, really good care, we have different babies. So currently, how we decide about the risk is the Indian RBSK guidelines, which, as Anand said, is the 2-3-4 rule. 2 kg and 34 weeks. All babies preterm 2 kg and 34 weeks should be screened, and babies more than 2 kg and more than 34 weeks have to be screened if they have other risk factors. Any baby whose gestational age is not well known, but the pediatrician thinks this is a preterm baby, we must screen. We are slowly moving towards universal screening, but currently we follow the RBSK guidelines.
And madam, what about that subpopulation where we have these micropremies, less than 1 kg? Are there to be screened earlier than the day 30 that you talked about?
Yes. So again, when we looked at the USA and UK guideline, it was very strange. I don't know how many of you have seen the American guidelines. The guideline says that if it is 24 weeker, then you screen after 9 weeks. If it is 25 weeker, you screen after 8 weeks. If it is 26 weeker, like every week the guideline changes. And then at the end of that, there's an asterisk which says based on insufficient data. So if you tell our health workers to follow that type of guideline, it will never work. I just took the leave from the polio program. Polio program initially said, give 1 dose, 3rd month, 4th month, 5th month. But on the ground, when our polio program worked, it worked because we said, jo bacha milega usko thok do. So just give that polio drop, because there was so much confusion. Mother has taken first dose, now should I give second dose? How will we know that? So what we decided in Pulse Polio program is, on the Pulse Polio Sunday, you give the dose. Same thing we decided here, 30 दिन रोशनी के. Every child must be screened before 30 days of birth. This is easy to remember. It is not based on gestational age. But the smaller babies, as you said, 26 weeker, 1 kg, 1.2 kg, or where there are suboptimal care, blenders are not there, number of nurses are less, there's more sepsis, mothers come from very malnourished background. Maternal anemia is a huge risk factor for ROP. We have published that. So those babies we should screen within 20 days. In fact, Anand also has published, and we also feel that, if the mothers are not going to come back for follow-up, please do one screening before they discharge, even if it is 10th day, 12th day, whatever day it is, because that will sensitize them that they have to come back for the follow-up. So yes, smaller babies, and this is again in RBSK guidelines. This is not my guideline. It is given in RBSK guidelines. Between 20 to 30 days, don't cross 30 days. 30 days is sacrosanct. But smaller babies, please screen earlier.
And many of these preterm babies, madam, are sick and maybe on respiratory support, maybe invasive or non-invasive. Would we still go ahead and do the screening?
Yes, yes. In fact, if the baby is on ventilator or support, it is in controlled environment. What we want is, yes, we don't want trainees to screen them. We have a lot of trainees all the time, so they can screen the stable babies. These unstable babies can be screened by the senior faculty. It doesn't take more than 10 minutes. In fact, it takes less than 10 minutes. At least they can see the basic, how is the retina growing, and they can also guide the doctor, the pediatrician, that, this baby has zone 1 retina. It has high risk of developing ROP. Please monitor this baby. This is the oxygen settings. This is the, nebulization and all that is to be done. Especially with anemia. If there's anemia, these babies deteriorate very fast. So during that period, critical period, we can guide how is the retina and what measures to be taken. So I have seen that with those measures, even the ROP can get postponed, or less severe ROP will occur. So it's a teamwork, and I don't think anybody should have, a worry that an unstable baby. Of course, if it is desaturating, we don't see at that time. But if they're on CPAP, or even lasers we have done on CPAP, on ventilators, they are fine.
Okay. Any practical tips in the process of screening that you would want us to follow? Specifically, that we are likely to overlook, or common errors that are being made?
Okay. One of the common errors we find is that the baby if they're twins or triplets, the babies who have gone home get missed. Because the parents feel the baby is fine, and the pediatrician also said this baby is fine, the other baby is sick, so you can go home and take that baby. So they discharge them early, and that baby doesn't come for follow-up. So please ensure, even if sometimes one twin is heavier than the other. So they think because one twin is 2.2 kg and the other one was 1.2 kg, so only 1.2 kg they will send for screening, not the 2.21. So prematurity is the highest risk, not the birth weight. Birth weight we take as surrogate measure of prematurity because we don't know the gestational age always. But the highest risk factor is prematurity. So any baby who is premature needs to be screened if it was less than 34. The second thing which gets missed is the hydrocephalus babies, or those born to diabetic mothers, because these are large for gestational age babies. So they may have higher birth weight, or they have hydrocephalus, they have so much of fluid or renal problem, intestinal obstruction. So anything whether it is large for gestational age or the weight is more, these babies get missed because people think that only low birth weight babies we should send. So please don't use only 2 kg, always say 34 weeks. So even, the hydrocephalus surgery has happened, but nobody has told that baby needs ROP screening. The third thing which gets missed is not, informing the parents in detail. So many parents, they say, ROP was written. How do we know what is ROP? So don't write ROP. Don't write ROP. Parents don't know what is ROP. Write that, aankh ke retina ka checkup karaiye. Okay, then you can write ROP also. But that's why I said if posters are there, then you have already told what is ROP and all. Otherwise, on the discharge slip, don't write ROP because they don't understand ROP Bera. We have to say, aankh ka jaanch and what date. I made a mistake once. I wrote that, parent has to come for follow-up on, 7-6- 2019. So I wrote like 7th June, 7-6-2019. Parent came on 6th July. And by the time the I was lost, I asked, why did you come on 6th July when I have written 7th June? He said, I stay in Dubai and we read the, American way. So I learned my lesson. I said, no, communication is important. Now I never write 7-6. I will write 7th June. So these are the lessons we learn. That one doctor from Bombay, that baby was in a very good hospital, very good pediatrician. So the pediatrician has written in the discharge, ROP screening on Thursday and given the date and time also. Not date. He has written ROP screening on Thursday, phone number of the ophthalmologist. They went late. I asked the parents, why did you go late? They said they have written Thursday, but they didn't say this Thursday. We thought we can go in any Thursday after 10, 12 weeks. So I think what we write, how we write, what we are writing, because we are so used to, but parents, they need very clear communication.
Thank you, Madam, for those insights. And having screened, how do you identify which of these babies would need treatment? Because not all babies with ROP would warrant for treatment.
So there are two criteria, and these are all based on randomized controlled trials. One is the ETROP study, which told us which babies to treat. But if you go through that article on ETROP, the last two paragraphs of that says that these are guidelines to diagnose severe disease, but the decision to treat an individual baby takes many things into account, and the ophthalmologist has to decide. So of course, if it is severe ROP like AROP, it is a stage 3 plus, we all treat. So they are given guidelines what to treat. Now in a given baby, I may not treat, because if the baby is gaining weight, if the baby has no lung problem, no nose block, no apnea, no breathing abnormality, completely clear airways, and there's no anemia, and baby has been gaining weight, and baby has been nurtured in a very good NICU, the parents are healthy, then these babies, if they are on borderline to treat or not to treat, I may decide to follow for a week or 2 weeks. Now babies who are higher gestational post-menstrual age, so the same type of retina in a 30-weeker I will treat, but if he is already 37, 38-weeker, I may not treat. An early ROP in a baby who's having still ventilation after 4 weeks, or who's still unstable, who had multiple transfusions, not gaining weight. So when we decide to treat, we have to take all these factors into consideration. What is the health of the child? Whether the mother was malnourished, how much oxygen baby received, what type of nursing care baby received, and then we can make the decision. But the stages that we have to treat, most of them, they are clear cut. There are only few gray zones, and this is how we decide. But if we decide not to treat, we always see within 3 to 5 days or 7 days.
Madam, in your experience, what percentage of babies who are screened are likely to require treatment?
Totally from where they come. If they come from a tertiary care center like PGI, I know less than 10% will require treatment, even tiny babies. If they come from rural area where there are no nurses, actually I went to Calcutta NICU in government hospital. Each bed had 3 babies. There are hardly any nurses, and our country is not going to get nurses overnight. I don't have nurses here. I keep on struggling for nurses, and the parents, they come from such, malnourished background. Those mothers are so anemic. What their babies are born with, they're all SGA babies. And, they, at the time of delivery, the first golden hour, too much oxygen was given or proper resuscitation was not given. So we know we can't have the best, baby is what we want. So yes, if it is from that type of area, then almost 30 to 40% will require treatment. But once we start treating and screening, we always keep on, improving the neonatal care, and then the numbers have come down. Any unit that we go or we work with, or now it is good, Deepak is here, so the NNF has been mentoring so many hospitals. In my city, Dr. Srinivas Murki, he goes to so many rural centers. He has started, training them in quality care, hand washing, breastfeeding, expressed milk, so kangaroo mother care. So these things have brought down the ROP. So ROP is sort of a quality measure of the quality care. It's not going to happen overnight, We don't have those materials and all. We may not have those blenders, everything, but I think things keep on improving, changing. So it is directly dependent on what type of maternal and neonatal care is there.
Very true, madam. And if this baby was to require treatment, what is the most ideal treatment for such babies?
So the ideal treatment is that as an ophthalmologist, I should be aware about one, the systemic factors. I already told every baby who has to be treated has to have the systemic factors improved. Many doctors, both neonatologists and ophthalmologists, forget this. Every time we have to check the hemoglobin, it should be more than 10. We have now OCT evidence and we have other evidence to show if there's anemia during the treatment of ROP, it will not go away. Same way with the lungs, with the weight gain, all that. So that is one part. Now, second part is that as ophthalmologist, I should know that their mainstay of treatment is laser, injections, and surgery. So what to use where is the expertise that is required. So it's like, I have all types of ammunition. I should know what does what. So a thorough understanding, because see, every case will be different. You will get cases which you had never seen before. You have to rake your brains and say, like, how am I going to treat it? There's no other expert to ask. So I think everybody, this is in general for doctors, if I'm using laser, I should know the basics. I should know what it does to the tissues. I should know what harm it causes. I should know how to deliver that. Same way with the injections, what are their uses, what is the dose. So I think the ideal treatment is that we want the disease to quieten, the baby to have good vision. And so it's not only the, because as neonatologists, you may be thinking only laser and injections, but we have to think of glasses, we have to think of follow-up, we have to think of CVI. Madam is here, Dr. Mukherjee. So many of these patients have delayed visual maturation. So vision stimulation, early intervention, everything goes side by side. Every visit, we emphasize to the parents the visual environment, how to improve the CVI. And see for other things, like if I expect the pediatricians to know about ROP, then as an ROP specialist, I should also know about apnea, about cardiac problems, PDA, about neurosonogram, hydrocephalus. Like I can't be treating a baby and seeing there's a big head and I don't know there's a hydrocephalus there, or send them back to the pediatrician. I think this baby is developing hydrocephalus, please look at it. So I think when we team up and we see these babies, the treatment goes beyond just laser and injection. It is complete health and neurodevelopment, and then vision, glasses, squint, so many other things.
And madam, if I were to just ask, if we had to use a treatment of laser versus say anti-VEGF, is it one-time treatment or is it recurrent? Which comes first and which comes afterwards? Because many a times once the decision has been made by the ophthalmologist, they come to us as to what is the further course of action.
So we had done a study, this was published, where we treated one eye with injection on day 1 and the other eye with laser on day 1, so that both eyes got a particular treatment. And then after 4 days, we switched and we gave injection to the laser eye and laser to the injection eye. And what we found was that both of these were very good. They all regressed, it didn't matter. But those eyes which had received injection first, they required less retreatments. So that is our recommendation, that if we are thinking of both the treatments, then we should give injection first. You can wait for 4, 7 days, 20 days, whatever, depending on how you're going to follow. And then you can do the laser later. That has better outcome in terms of not needing too many retreatments. Now, laser usually is a single treatment if done by an expert. Sometimes we need to add some more, a second sitting. But sometimes those who, as Anand showed, do homeopathic treatment or laser is not very good, or sometimes media is not clear, pupil is not dilating and we can't complete the treatment. We must complete the treatment within a week. We should not do one sitting and then wait for 2-3 weeks and then do second sitting and then wait for 3-4 weeks before we make a decision. The disease progresses very fast. Decisions have to be made within 3 to 5 days. And if the retina starts detaching, we must operate immediately. Sometimes the baby is not fit for surgery and I have to operate after 2 days or 3 days. It has massively worsened. So no, so I have to really work with my anesthetist to, push them to take high risk cases, 1 kg baby, baby on ventilators, on tube feeding and all those things. So if surgery is needed, please counsel your patient that this is emergency. Please get the surgery done early. And of course, the neonatologist will be there, standby. And, we'll need all the other experts, cardiologists, neonatal anesthesiologist. But surgery for stage 4A is an emergency. It has to be done immediately.
And last question, madam. When we talk about the follow-up for these babies with ROP, is it for blindness alone? What else are the problems that these babies are likely to face? And how long should these babies be under follow-up?
So what we decided in our program, which is a prospective program from 1998, we had to have a cutoff. Where do I stop? So we said that all babies we will follow till 5 years of age. That means our aim is that they should go to school with the best possible vision. Okay, and best possible vision, as I already said, is not just the retina. It involves spectacles, it involves early intervention, cognition, speech, everything. Dyslexia, we do see a lot of patients with dyslexia, and they think because they're wearing glasses or they had laser, that is why child is not performing at school. And then we have to tell them that no, child's vision is adequate to do the work. He's got learning disability, so like that. So up till 5 years, yes. So those who had no ROP, we follow them annually and ask the parents, if you notice something like a squint or something, then please come earlier. Again, because all pediatricians are here, if any child has squint, don't tell them, it will go away. There can be retinoblastoma behind, there can be retinal detachment behind, there can be torch infections behind. So please refer. Don't take it on yourself to say that, ye chale jayega. All squint eyes have to be examined. So that is one part that we follow them annually. Those who had no ROP, we just follow them annually, see their glass power. Sometimes they can have anisometropia. If they had mild ROP, we follow them 6 monthly if they did not need treatment. Those who needed just laser, after first 3-4 months, we follow them every 6 to 9 months. Injection babies, we have to follow till we are sure that retina is completely vascularized, which may take sometimes 3 months, 6 months, 9 months. At some point, we may do laser, we may not do laser. But usually after 8 to 9 months, we are quite comfortable that they are doing well. Then we follow them like the laser babies. Those who needed surgery or had complicated condition, or those who were blind or near blind, so they of course need low vision setup, and we follow them more closely.
Thank you so much, madam, for those clinical insights. So the key messages that I learned from you are that A, keep gestation as a high priority when you screen these babies for ROP. Keep an eye for ROP on day 30. That's a golden rule from your side. And it is mandatory that we give verbal and written instructions for follow-up with details to the parents. Communicate. And more importantly, the treatment has to be customized based on the systemic problems of the baby and the eye findings. And last but not the least, an extended follow-up, even if the baby is treated, would be needed for these babies with ROP at least till 5 years of age. So thank you so much, madam, for all those clinical pearls that you shared. I always feel that you have saved every time 1 crore of rupees for the pediatricians, simply because the cost of missing is too high for us. And if we see the data, all the medical legal cases where compensation has been offered, all those have been against the pediatricians in general, and only one time an ophthalmologist has been involved. So the message is very loud and clear. The onus of getting the screening is on the pediatrician. The onus of screening and treating is on the ophthalmologist. So thank you, madam. I think that crore of rupees people will remember to get everybody screened. So, yeah, madam.
But I think the pain and the shame of having the child whom you nurtured in your NICU, brought up, now going to be blind for life is so much. I mean, I have made mistakes. I have made mistakes where I, judged that I don't need to treat and patient became blind, or, I didn't pick up a finding. So that pain remains for life, whether coror is there or not there. And the coror is, of course, added to that. One small disease I wanted to say, because you asked me what other problems these babies can get, I have published. These babies can get endogenous endophthalmitis. And what happens, the sign, because they are on antibiotics, the only sign you will see is a red eye with some periocular redness. Now, what we find is that whenever there's a red eye, the pediatricians in general have a tendency not even to examine the eye, they just give tobramycin or Vigamox or Ciplox. They think it is conjunctivitis, which of course is very, very common, or they think it is an NLD block. So please don't advise antibiotic without at least opening the eye and seeing with the torch how the pupil reaction. Is the cornea clear? Because endophthalmitis means that these patients will have Pseudomonas or Acinetobacter or Klebsiella or even Candida. So they need immediate treatment. Otherwise, they get delayed. So endogenous endophthalmitis in preterm babies is a well-known entity, because they get other sepsis, so they can get eye sepsis also. The international guideline for Candida is that if any child is on IV line for more than 2 weeks, their retina has to be screened whether they are preterm or no preterm within 2 weeks of the IV line for Candida.
True. So we have had the ophthalmologist's perspective, and what we also realize is ROP is just the tip of the iceberg, as it is a reflection of quality of care that we in our nursery are providing. And we do know that the two key risk factors for development of ROP are gestation and birth weight, which are non-modifiable, and obviously essential obstetric care, in utero transfer for high-risk pregnancies, and antenatal steroids for those with threatened preterm labor will go a long way in ensuring that the risk of ROP in these babies will reduce. But the point is that we have modifiable risk factors, which would be the key elements of change that each one of us should practice, these and which would be what we would learn from our experts. And the biggest culprit for development of ROP is oxygen. And oxygen is the first intervention that we perform for any baby with ROP, or with any baby who is sick. And little do we realize that we may end up with a disaster. So may I ask Madam Mukherjee, how do we start we optimize the use of oxygen, and the story starts right from the birth in the delivery room?
Thank you very much, sir. Good evening, everybody. And I must thank Dr. Suman for inviting me and giving me the chance to hear from Dr. Vinetar and Dr. Sumatra Jalali, madam. And I'm so happy that madam has told about the brain of baby and the long-term follow-up. Thank you very much, madam. And now we are back with the oxygen story. Yes, sir. When we start any discussion from pediatrician and immunologist, so oxygen comes first. And around 80 years has elapsed since it was noticed that oxygen is the...
Madam, we can't hear you. You're muted. Yeah.
Sir, can I?
Yeah, we can hear you now. Okay. Yes, please.
So, sir, till now the optimal concentration of oxygen starting from the delivery room and in NICU in preterm baby is not clear. And sometimes very challenging also, especially in the resource limited settings, how to deliver oxygen is more proper way, and just to maintain a proper oxygenation to prevent.
Madam, you are muted again. Yeah.
So now we'll start. I am very fortunate that I am working in a government hospital where we have a very controlled environment, and we get these equipment, say the blender in NICU and this Massimo pulse oximeter in delivery room. So we can start our resuscitation with this preparedness, and if young preterm baby is delivered, the oxygen is used according to the NRP protocol, and if it is less than 35, then it is 21 to 30, and it is more than the room air. But sir, problem is in the resource limited setting, and if in our case The delivery room CPAP can be used if the baby is having distress before transporting the baby to an ICU. Sir, I have an experience in working in a SNCU, district level SNCU for last 10 years, and I have seen there these things are missing. And the main contributor of this ROP, because some moderate and late preterm babies are surviving, and sometimes the less than 1 kg babies also. So we have seen in a district level SNCU, around 1250, less than 1250 gram, they have this bulk of ROP and the severe most ROP. So this is for one center, and this number of centers in all over India, and these they are contributing the severe most ROP, not the medical colleges. And now, sir, how we can improve this oxygen delivery system in the resource limited settings? Sir, in NICU, we are using this oxygen target, and in the monitor and pulse oximeter, there are alarms. But what is more important is the regular monitoring of the nursing staff. And it is a continuous education of them. It is not like you have set on protocol and after 3 or 4 months, you are thinking that everything is going fine. But the ophthalmologist just visited you to tell that there is a rise in ROP and this rise in the incidence of laser in your unit. So sometimes this happens in our unit also because we have a very close liaison with our ophthalmologist. But sir, because we are having this target system, but one thing is lacking is the continuous education. That is very important thing and mandatorily performed all these unit in charges of all medical colleges. But in district, the problem is that now the blender is available, not the delivery room CPAP. And nowadays the CPAP machine is supplied in the district SNCU, but they are not adequate. Because madam has already told that the number of babies are much more here. There is twin sharing, sometimes the 3 babies in a cot, in a warmer. So it's very difficult for the nursing staff also to use this alarm for each and every baby and the monitoring. But in district level SNCU, most of the units now they have this Massimo pulse oximeter. They can use it in the delivery room. Even they are not having this delivery room CPAP or blended oxygen supply in the delivery room. But according to, they can stop using the excessive oxygen. I have seen in the district few years back, they are using this high flow, not the high flow nasal cannula, ordinary this high flow oxygen, tightly wrapping around the baby's nose and giving a high pressure like thing in a futile attempt to decrease the rate of desaturation and decreasing the rates of apnea in SNCU, just to increase the ROP number and the severity and increases in the laser therapy and poor long-term follow-up. So what we can do in the SNCU also, this alarm system, because they are having this Massimo pulse oximeter, most of the units are having. So awareness of the nursing staff and the residents also, whenever it crosses the alarm limit, and prompt response to the alarm and just to decrease the FiO2 to whatever respiratory support they are using. Now, these are also good practices, and what madam was telling, that it is not only the oxygen, but the entire this SNCU environment, this nurses training, this readiness to respond to the alarm call, the less infection, more and more these using these breast milk to the babies. But oxygen is the main thing. If we do not have this blender, but using this pulse oximeter and the preparedness and the awareness, we can decrease this oxygen injury, not only to the eye, but to the brain also.
So thank you so much, madam, for all those practical experience sharing. And the key messages that came from you was that use oxygen as a drug and target, titrate, and monitor use of oxygen. And the key important factor is that you continue to have education of the staff nurses, ensure that alarm limits are being set. And more importantly, we must realize it's not hypoxia or hyperoxia per se, which is going to cause ROP. It is fluctuation in oxygenation that is equally detrimental that we need to keep aware of. And what it requires is oxygen stewardship, if I have to use that word, which will take care of all these multiple strategies that we need to look at. So thank you for the practical tips on usage of oxygenation. Any baby who is otherwise preterm following oxygenation continues to have an immature lung, and it is but natural that these babies need some form of respiratory support. And my question here is to Dr. Deepak, how do we optimize the use of respiratory support? Your key messages of all evidence-based practices.
Good evening, Dr. Rishikesh. Can you hear me?
Yeah, we can hear you.
Okay. So based on pathophysiology and risk factors of ROP, while we provide various respiratory support interventions, we want two things. First is to minimize the need for and duration of exposure to respiratory support. And second, while giving respiratory support, minimize the exposure to both hypoxia and hyperoxia. Now, if you look at the first thing, the need for and duration of respiratory support can be minimized that if you monitor babies for onset of distress and start early CPAP. Use of early CPAP is associated with less need of mechanical ventilation and lower duration of respiratory support. And if baby meets the threshold for surfactant, then give surfactant early enough. So by using early CPAP and early surfactant, one can decrease the exposure to respiratory support and oxygen. Now, if baby goes on to receive invasive ventilation, again, our goal should be to minimize the duration of invasive ventilation. And there are 3-4 things which we can do. Number one, if baby is on invasive ventilation, ensure that baby is on one of the patient-triggered modes of ventilation, SIMV, PSV, whatever is available, preferably with volume-targeted options, so that the respiratory gas exchange and blood gases are stable. Second, one very important culprit of prolonging need of respiratory support and also a risk factor for ROP is infection, that is either late onset sepsis or ventilator-associated pneumonia. So it is important to have a VAP prevention bundle in these babies who are receiving invasive ventilation. Third, of course, is the role of caffeine therapy to minimize the extubation failure and need of reintubation. And fourth, very important, which we many times forget, is adequate nutrition, even if baby is receiving respiratory support. So nutrition is important to reduce the duration, and it has direct effect on ROP also. So all this can be done by following a standardized protocol for extubation in a unit, so that how will you ventilate, at what setting you will give CPAP, surfactant, and so there had to be a standardized protocol. That is number one. Second thing during ventilation is to prevent exposure to both hypoxia and hyperoxia. So even hyperoxia, although hypoxia many people recognize is important for prevention of ROP, even hypoxia is important because episodically baby going into hypoxia is even more dangerous than only hyperoxia. So first of all, assessing each baby at time of admission for need of oxygen supplementation. And so many times in FNCUs, it is seen that whatever baby comes, first they start oxygen. But it is important to look at whether baby actually needs oxygen. So SNCUs should have adequate number of pulse oximeters to assess baby at admission. And once oxygen starts, to keep monitoring these babies and keeping the target saturation between 90 and 95%. So all this should be done. Many ventilators now have option to have feedback control of oxygen. And as units start buying new ventilators, especially those who can afford, can also look at these ventilators which can have feedback loop of oxygen control, so that we can have better control of oxygenation in these babies.
And so what Deepak has tried to share with us is that we need to have a respiratory bundle when it comes to caring for such babies. And it's not only respiratory interventions in the form of CPAP, surfactant, or mechanical ventilation, but a comprehensive ongoing continuous care, which also looks at nutrition, use of caffeine, and other such adjunct therapies. And obviously, there is a learning curve whenever we have any of such technology entering into the nursery. Any harmful practices that we need to avoid, Deepak?
while providing respiratory support?
Yes.
Yeah, so I think one of the most harmful practice which is directly related to ROP is uncontrolled use of oxygen and babies having high oxygen saturation for a long time. So setting alarm limits and responding to those alarms is important. So we know from the studies which have looked at different saturation limits that although baby, if you keep saturation between 90 and 95, the incidence of ROP will be slightly higher as compared to keep saturation between 85 and 90. But we see many units in which alarms are turned off and babies having saturation 99, 100%. And many times even nurses or doctors may not be aware, they want baby to be saturating more than 95%. So that is very harmful. So that is one thing which we need to prevent in these babies. And second, I think not delaying extubation, trying extubation so that baby can come off invasive ventilation to non-invasive ventilation. That is also very important.
Yeah. And any role of prophylactic surfactant, which came in a big way?
So as I said earlier, that start with CPAP, and there are now set guidelines that when to use surfactant. At present, these say that if the need of CPAP is pressure of more than 5 to 6 centimeter of water and FiO2 of more than 30%, then give surfactant. So prophylactic surfactant is as of now out. So unless baby is less than 28 weeks and baby needs intubation and delivery room, then you can give surfactant without looking at whether there is HMD or not. Otherwise, in all babies, one would start CPAP, non-invasive ventilation, and then see how baby responds. And usually most babies will come out with CPAP, especially if they have received antenatal steroids.
So the key here is early CPAP, early surfactant, minimize the duration of ventilation, make use of multiple modalities of adjunct therapies that will make the respiratory care more optimal. So thank you, Dr. Deepa. The other problem from oxygen and respiratory care, which is modifiable, is infection, and that's a big elephant sitting in the NICU. And invariably, we would have these babies on antibiotics who are preterm. And we do know that as much as antibiotics can save life, they also harm the babies. So, Dr. Sandeep, how can we optimize the use of antibiotics? So what are good antibiotic policies that you would suggest?
At the outset, I think we need to have a standard antibiotic policy or protocol in the unit. Most important, I think we need to have a good infection preventive strategies and minimize the use of antimicrobials in the unit. We need to have a clear written protocol as to when to start antibiotic, which antibiotics to start, when to stop antibiotics. I think we all are very energetic and enthusiastic to start with, whether it is antimicrobials or ventilation or intubation. We need to have a very strict action in terms of stopping antibiotics. So we need to have an exit policy. We need to use the antibiotic in the right dose, right route, and right choice. We need to have a habit of taking cultures so that if the cultures are negative at the end of 48 to 72 hours, we can safely stop antibiotics. We need to also have an antibiogram in our unit, which may be unit specific, because many times we are asked which antibiotics to start with in your unit and can I use it in the other unit. So I think every unit will have a different bug and every unit will have a different protocol or antibiogram and sensitivity, and depending on that, we need to design our own antimicrobial therapy. Use narrow spectrum antibiotics, and most important, don't treat colonization, don't treat report, treat the patient, treat the baby with infection, and avoid excessive use of antibiotics. Because if you look at certain studies, to treat one culture positive baby, you may be treating 25 or 30 culture negative infections. And I think we need to use our sepsis screen very diligently. If your two sepsis screens are negative 24 to 48 hours apart, I think we can reasonably stop antibiotics with much more confidence. And we need to have QI, quality improvement initiatives, to use antibiotics and stop antibiotics in our unit. So I think that's where we are in terms of optimizing usage of antimicrobials in NICU.
So what Sandeep has shared with us is antibiotic stewardship and the antibiotic mantras, if I were to call it, which are very simple key practices. As we enter into the second or third week of these preme's, we realize that systemic fungal infections start setting in. The point is, once fungemia sets in, it's again an independent predictor for developing ROP. So how can we prevent such systemic fungal infections from setting in? What are good clinical practices?
We all know that invasive fungal diseases are associated with a lot of mortality and morbidities. And it's clear association with ROP in the current context, because if you see a fungemia, there's a very high risk that this baby is going to have aggressive or retinopathy of prematurity needing treatment. So I think in order to prevent systemic fungal disease or invasive fungal disorders, we need to have very clear infection control protocols. Number one. Number two, avoid broad spectrum antibiotics. Use mother's milk. Avoid long lines. And if required, only one should put a long line and follow the CLAPSI bundle. Use breast milk, because that's the key. Today, we are talking of giving full enteral feeds in moderately preterm babies in order to minimize IV-related injuries and IV traumas and central and associated bloodstream infections. So basically, we need to have asepsis, and asepsis. You need to follow bundles, whether it is VAP bundle, whether it's CLAPSI bundle, whether it's IV care bundle or a feeding bundle. Be aggressive, and mother's own milk dose-dependent response to minimize infections is very well known and documented. Now, if your unit is still seeing more than 10% of invasive fungal disease, it is time to relook what are the fomites, what are the sources, and identify, fumigate, have an infection control nurse to look at the possible sources, whether it is TPN, your laminar flow, or warmers and wash basins, which may be the source of fungemia. And last but not the least, in terms of preventing fungal infections, there are certain units which are looking at prophylactic antifungal, where your invasive fungal infection rates are very high. Whether it's prophylactic fluconazole, maybe using biweekly in extremely low birth weight babies, or oral nystatin, people have tried to reduce invasive fungal disease. So basically, I think we need to prevent rather than treat invasive fungal diseases. That's my take on it.
Yeah. So any onset of unexplained hypoglycemia or thrombocytopenia in the second week of life should alert you to the possibility of candidemia. You must do a blood culture, and there is no role to start routinely a prophylactic antifungal for these babies. Lastly, Sandeep, how do we ensure that our nurseries remain bug-free?
I think it's the need of the hour, very difficult question. We have broad principles, maybe difficult to implement because of lack of personnel. But if you look at how to keep our SNCUs and NICUs infection-free, don't allow the bug to enter your NICU. So how can we do that? Have a clean environment. Have your NICU design, which is standard. You can't cramp warmers into a room and say that I've got an NICU or SNCU. We need to have hand washing stations and see that we follow hand hygiene to its core. Prevent proliferation of your microbes in the NICU by good housekeeping practices and protocols. So we need to take on board our nurses, our housekeeping personnel, so that they form a team to keep our NICUs clean. Prevent spreading of bugs from one baby to another baby. And for that, we need to have a good nurse to baby ratio. We need to have hand hygiene, use disposables, have laminar flow to prepare IV fluids and TPN. And most important, if your bug is there in the NICU, how can we prevent that entry of the bug into the baby? We need to again have clean cord practices, use mother's milk, start early feeding, use colostrum, use kangaroo mother care, use less and less of central lines and less for intubations and more of non-invasive, because herein we need to realize that less is more, especially when it comes to invasive ventilation or whether it's related to long lines and TPNs. Use mother's milk, and last but not the least, we need to have early discharge from the unit so as to optimize the nurse and baby ratio, involve mothers in the care of the babies so that these babies will get more skin to skin contact, more mother's milk, and less of infections. And that's, I think, how we can improve our quality of care and keep our NICUs infection free.
Thank you, Sandeep, for that comprehensive infection control policies. The bottom line remains, whether it is early onset sepsis or late onset sepsis or fungal sepsis, each of these is an independent predictor of ROP. And the best way again is not to treat, but to prevent such infections from setting in. So we move to the fourth modifiable risk factor, and we do know that birth of a preterm is a nutritional emergency. And many of us get lost in the care of these preterms, especially in the first week, where we chase the respiratory care or the infections, little realizing that we have a blind spot to nutrition of this baby. And we do know nutrition comes in the way and is an independent predictor, again, especially if there is slow weight gain that sets in, which leads to development of ROP. So Dr. Pradhan, may I ask, how do you optimize the use of mother's own milk in your nurseries? You are muted. We can't hear you. We can't hear you, Dr. Pradhan. I think there's an
Yeah,
audio problem.
we can't hear Dr. Pradhan, though he's unmuted. He's
I
not
think there's some, I think there's some problem with the audio system.
Dr. Pradhan, we can't hear you. Okay.
Okay, so till you get the audio working, we'll move forwards and come back here later. Are you with us, Dr. Pradhan? Okay, so the optimization of mother's own milk obviously is a big challenge, simply because we do know that mother's own milk is the most complete food when it comes to meeting the nutritional, immunological, and psychological requirements of this baby.
Are you able to listen to me?
Yeah.
Hello?
Yeah, please start. There's an echo which is coming. Yeah.
Now able to listen to me?
Yes, please continue.
Sorry for the delay. Thank you, Dr. Suman and Dr. Rishikesh, for the nice opportunity. As you know, the poor nutrition is an igniting factor in causing ROP. Nowadays, we are fortunate to use the word mom, that is mother's own milk, rather breast milk. So it is the best form of nutrition for the preterm because it avoids necrotizing enterocolitis, ROP, sepsis, and less BPD. But the problem is we are not able to get the milk so soon because mother is at times distant from the baby. Mother is full of anxiety because she is not aware that I have got such a small baby. What can I do? She is shy at times. She also feels poor that she has got a girl child. So these things should be approached, and one has to see that we get the preterm milk very soon, because preterm milk is the best form of milk for that preterm to avoid retinopathy of prematurity. For that, we must have to see that the early expression is there. For early expression to happen, mother should be around the baby. If mother is sick, the baby, if mother is sick, baby is sick, mother should visit the NICU, and the baby should be around for the expression. And the expression, best method of expression is of course manual or pumps. One can use manual pumps or electric pumps, but in a resource restricted areas like ours, one can use manual pumps for that purpose. And For expression to help, mother should have the help of peer groups, lactational management, support groups, and if baby is in the NICU and only on IV fluid or in the oxygen, mother can have a short KMC inside the unit also. And nowadays, another thing has come out that immediate KMC or IKMC. Babies who are more than 1 kg are not in respiratory support, not apneic, having no need of oxygen or in respiratory distress, can have IKMC in the labor room itself and supported by the healthcare providers then and there. And from that point, the mother can be helped to come to the NICU, and the NICU she can have expression also. So expression is an area, and IKMC should be followed, and also short-term KMC should be followed for the optimization of the milk. Another thing is we must see that baby and mother are never separated. During pregnancy, they were all together, and placenta was the key factor, was the modifying factor, and was the assisting factor. After delivery in the labor room, the healthcare providers should help so that the baby and mother are together. And after that, in the family, the home members and all the healthcare providers like ASA and NO should help that baby and mother are not separated, so that we follow the policy of zero separation from the time of conception even to the afterwards of the postnatal care.
So the key point is, as much as we are tracking the oxygen saturation, the sepsis profile, the blood culture, the oxygen, and multiple things, track the lactation, track the breast milk being there as our first priority when it comes to feeding these babies. So we also realize that we fall short when it comes to nutritional supplementation of these sick preterm babies. And extrauterine growth restriction is a known risk factor for developing ROP. So how can we prevent this growth failure from taking place, Dr. Pradhan?
Our target should be extrauterine growth should match always the intrauterine growth. That should be the aim and objective in the mind, to prevent that baby is not going to restricted growth postnatally. So for that, if baby is less than 28 weeks or less than 1 kg and satisfying the qualities for TPN, we should go for TPN if that baby satisfied that. Suppose the baby is more than 28 weeks and around 30 weeks and is stable, then we should go for early total enteral feeding. And if baby is little bit sick and more than 1 kg, we can go for trophic feeding, or what we call as the priming, or call as the minimal enteral feeding. So these are the 3 types of approaches for the low birth preterm babies. Choice of milk will be again the mother's own milk will be best target, best choice for such babies. And second choice would be, of course, donor human milk. Donor human milk, in many banks like ours, we don't have a preterm milk. Term milks are there, but evidences suggest that there is hardly any difference between term milk or preterm milk. But of course, if preterm milk is available, that is good. But the problem is that with pasteurization, there causes some zero levels of C3 complement, IgM, IgA, and DSL. Those are the limiting factors for using a donor human milk. The third option will be, in absence of mom or DHM, with or without fortification, we should go for the preterm formula. But the limiting factors are the post contamination and more happening of neck. So choice is mom's own milk.
Yeah, and studies do show that any milk is better than preterm formula when it comes to prevention of ROP. There is dose-response relationship with the milk volume, with protective effect for ROP. And last but not the least, every time that we have any preterm, we must target 2 things. A, we must note what is the time to first feed, and B, what is time to full feeds. If we are able to match this gap, we would be able to ensure that we would have a good growth, in addition to good enteral and parental practices that Dr. Pradhan talked about. And the last preventable factor in the development of ROP is blood transfusion. And we know it is any increase in volume or frequency which predisposes for developing ROP. So, Madam Mukherjee, what would be good strategies that would prevent blood transfusion from occurring, especially in these preterm babies? You are muted, madam.
Another most important point in preventing ROP is the blood transfusion, this rationalization of transfusion and this judicious use of blood products. That most of the cases, the preterm baby is born means it is synonymous with oxygen use. Preterm baby means we have to give some antibiotic, and preterm baby means we have to give PRBC. So this is not the case actually. We have to rationalize for each and every transfusion. So if we can start from the labor room, the one that is most effective is delayed cord clamping. Now it is becoming the standard of care for premature babies also. So delayed cord clamping is not only reduces this number of transfusion later, but it also makes the baby hemodynamically stable so that there is a changes in blood pressure, and with that this hypoxia and hyperoxia that can be prevented, and that there will be less chances of ROP and severe ROP. If this delayed cord clamping cannot be used or cannot be implemented in all delivery rooms, that another option is the umbilical cord milking, but still these evidence are not robust till now for premature baby to use it as a clinical practices for all the units. Third, sir, which is most important, is the minimization of these investigations. Because I have seen these residents, even in night shift, they are more energetic for drawing blood. The baby, preterm baby, is looking pale, but she's slightly off color. The baby is not moving properly. Baby is not looking well. That means you have to do one sepsis screen and a blood gas and electrolytes. And in the morning out, they will be ready with the reports for this 28-weeker baby. The baby's weight is 1100. And this all investigation, every 3 or 4 days, the residents are doing in their own night shift, because she in the morning round, they have to face the consultant. So again, these practices should be stopped. One good thing in neonatology that everything is having a protocol. So like oxygen uses, like our antibiotic stewardship protocol, like our giving breast milk, and that blood transfusion guideline. There is an NF guideline for the transfusion, and it is for invasive ventilation, non-invasive ventilation, and no respiratory support is the restrictive blood use. But still, if that is in protocol, but every consultant and every resident should strictly adhere to the protocol, and in between there should be checking by the consultant, like a vigilance or as a quality improvement. The last month, how much blood product has been given for which indications. Unless it is done, it's very difficult to minimize the irrational blood products transfusion in the NICU. Few things are coming up, like erythropoietin. It is not recommended routinely. Oral anti-iron supplementation is not helpful for less than 2 weeks, less than 2 months, 8 weeks, but later it may prevent the anemia in the early infancy. But still there is a scope for improving these investigation facility with the point of care instruments like bilirubin estimation. If we can use the transcutaneous bilirubinometer or blood gas analyzer, where we can use the very small amount of blood, then the actual volume required for the investigation will be minimized. And our awareness, the last thing is all residents, all the consultants should be aware what are the permissible amount of blood from a baby. Say it is a 600 grammer baby, maybe 700 or maybe 1200 gram. So maximum permissible limit of doing an investigation should be maintained in a unit. And there should be protocol, the clustering of the investigation. So when you are sending for this bone profile, we can use it. The same sitting, we can use the hematocrit and other investigation if it is pending. So I think these things can be implemented in all units just to reduce the blood transfusion.
Thank you so much, madam. I think madam has brought out two key messages. A, treat the baby, not the numbers. And B, do follow guideline thresholds that will help reduce your transfusion numbers. And lastly, the most under-recognized factor is the nurses and their role play when it comes to ROP. So Dr. Deepak, could you elaborate on how how nurses would influence ROP?
So, as for any other disease or therapy in neonatal unit, nurses are important for prevention, diagnosis, and treatment of ROP also. So many preventive actions, including oxygen control, infection prevention, nutrition, use of breast milk, KMC, or all of these dependent on active role of nurses. And then if you look at screening examination for ROP, or you look at treatment, nurses help in preparing the baby for examination. They will apply pain control measures. They will, many times, they are the primary person who are counseling parents and giving them soothing words. And of course, when the procedure is being done, they will help ophthalmologists in conducting the IO examination, or once laser is done, then doing post-procedure care. So nurses have role throughout in prevention, screening, and treatment of ROP. So I think it is very important that nurses are trained in all these aspects, and not only as a pre-service component, but also once they join or in between, as in-service training should also be done. And this is one aspect. Another aspect which is seen and which Dr. Anand also highlighted in one of his publications was that large number of small cities or district hospitals do not have an ophthalmologist who is trained in ROP, and actually many districts have not even one eye care provider. So studies have now looked at different models, how screening can be done. And one model is, of course, KidROP model. And another model is newborn care provider-led model, in which either pediatrician or maybe even nurse can take an image either with a retinal camera, which is wide field, or from a cell phone mounted lens. At least you can look at peripheral posterior ROP. So nurses may have a role in some centers, even for screening and sending these images.
So thank you, Dr. Deepak. Nurses remain the backbone of the NICUs, and studies do show that a poor nurse-patient ratio is, and again, an independent predictor for development of ROP. And lastly, we come back, madam, to you. On an average, it seems that we would have at least 3 screenings to be performed for every preterm baby. And it is a mammoth task in our country with the limited resources and ophthalmologists. What do you foresee the role of telemedicine and artificial intelligence for ROP?
Thank you. All the discussions have been so good. I think everybody is working towards vision and reducing ROP. Thank you. So I think that, the important thing is that everything should be balanced and hand in hand. So when I started, I resisted telemedicine only for one reason, because the camera was, 99 lakhs. And for a poor country like us to have so many cameras, and the company was not willing to come and repair if it went off. So, for months together, it would be off work. So using that as the strategy to care for our babies was not correct at that point of time. So I encouraged people to train, to come and learn. And every month I train 2 people, one on one eye. And all these years we've trained more than 350 doctors, not only in India, but all the surrounding Southeast Asian countries, right up to Italy and China. So using indirect ophthalmoscope and training, because somebody may screen and then somebody has to treat. Now there is no camera for treatment. The doctors have to treat with indirect ophthalmoscope. So, so at that time, there were no doctors to treat also. So my aim was that everybody should learn to screen and treat. Because if you screen, it is illegal or, unethical to screen and then not provide treatment. Then how does the baby go and where does it go for treatment? So that is why we started like that. But today, when the camera cost has come down, there are many more cameras available. If you Google type ROP cameras, you will find 40 different cameras, different do-it-yourself cameras, available cameras, and the cost has come down and they are much more widespread, and that can be learned. So definitely today, I think now we have many doctors who can treat. So we can have a large number of people who can screen. Now everybody who screens doesn't need to treat. And in our Anand already has shown for so many years the RedCam based telemedicine. Now our Bhubaneswar Center Tapas, he has shown live teleconsult through Zoom. Now the whole country and all the people are very used to this Zoom technology and the camera. So the other thing which has happened is now everybody knows how to use a camera. Initially for us to train with the camera was also difficult because people didn't know how to save images, how to transfer files. Now everybody, right from 5-year-olds, know this camera, taking photos, sorting images, what is good image. So that has really helped, that people can really take good images. We can also do live imaging. When they take the image, we can guide. I think in today's world, the connectivity is an issue. Anand, he used to use some, satellite internet, which was not available to everybody. Then we can use the internet phone lines, so that is a deterrent, that if suddenly the internet goes off, then there's a problem. So that is why, even though now we encourage telemedicine, still we want that along with the telemedicine, the local doctors should also learn how to look at the images and how to interpret these images. And that is where the AI will also help. Again, the AI is going to help us to interpret some of these images, but there is, to my mind, nothing superior to human brain and human heart. The subtle things which I told, like, whether the baby is gaining weight or not, or what should be the optimum weight for this baby, whether baby is breathing properly or not, whether its nose is blocked or not, should I screen, how much time I can. So, all those subtle things requires the, human touch of the doctor to be there and make those decisions. But yes, I think both the telemedicine and AI are advances which are going to assist us in addition to what all we do. So where there is nothing, there they can help, but where there is already something, I think we should use them as add-ons rather than, get lost in the technology and forget the care.
Very true, madam. So as we come towards the end, what have we learned? That the best way to manage ROP is to prevent it. And we learned 5 key modifiable risk factors through our experts. The first that we learned was refer and treat timely when it comes to eye. Optimize oxygen, optimize nutrition, that's the key. And lastly, prevent lung injury, prevent infection, prevent transfusion. Simple, low-cost, effective, evidence-based practices that each one of us in today's era, in our unit, with whatever are the resources available, would be able to practice. And this would be a small step in preventing the incidence and severity of retinopathy of prematurity, and in turn reducing the blindness, which otherwise is a big burden, not only on the child, but also on the family, and so also on the society and the country at large. Let me end by saying, you can't go back and change the beginning, but you can start where you are and change the ending. And that is where each of us as newborn care providers must endeavor to give our best when it comes to providing evidence-based newborn care. So thank you so much. I am grateful and thankful to our expert faculty, Madam Jalali. It's an honor to have you with us today for this panel discussion. Madam Mukherjee and Dr. Pradhan, and more importantly, our evidence-based man, Dr. Deepak, and lastly, infection specialist, Dr. Sandeep. So thank you so much for your critical inputs. And thank you, Dr. Suman and Dr. Naveen again for the opportunity.
Thank you so much. This was just wonderful. ROP, children are not born with ROP. It happens when they are under our care. So while the child may be born with lung problem, PDA, so many things, but ROP happens while they are under our care. So it's such a great opportunity. It's a preventive cause of blindness, because they didn't have it when they came to our unit. They got it under care, and we could prevent that blindness by just being vigilant about it.
Thank you everyone. It was really wonderful. There were a few questions again in the chat, and Dr. Anand has reciprocated Dr. Subhadra by responding to them. Thank you very much. If there are any further questions, we can take them, but I think the whole panel has been really comprehensive, and the best part was it made it look so simple that yes, something we're all worried about as the most important medical legal issue in newborn care can be prevented by such simple, good neonatal care. So thank you, Dr. Rishikesh, and through your panel for simplifying this. Dr. Pradhan, would you like to say something?
Yes, ma'am. As you know, we are following up SNSU babies for 1 year. So as Jalali madam has told, we are missing follow-up cases because at the end of 1 year, we don't have an opportunity to see these babies, what is happening, they are growing eyes. So can you make it a point that SNSU follow-ups should be made for at least for 5 years? That is one point. Second, all these things which we are discussing are institutional based. Can we go down to community? In the community, we should give handholding support, and ASA, Anganwadi workers and family members, they should be aware of the fact that one should have examination of eyes once there is small babies, because all small babies are not coming to the hospitals. And moreover, the posters which are using, booklets which are using, it is only available in the urban areas. It is not available in the unreached areas. So there should be an educational program and booklets and teachings in the rural areas where most of the babies are there. Can you just get it down?
Thank you, sir. Thank you for taking this forward. Yes, we need to move from the facilities, but we also need to realize that ROP is also created in the facilities. So I think starting in the facilities is a good pace, and our follow-up, I think everywhere needs to improve. Even 1 year follow-up is so difficult. And yes, we need to follow them up for a long time. So Chandra, would you like to say something?
Yes. Sir, just to respond to Dr. Pradhan's, because SNSU follow-up is definitely till 1 year, but for ROP follow-up needs till school age, as Madam Dr. Jalali has already pointed out. So we can send those baby to nearest district early intervention center. Their optometrist will be there to screen for any retinal problem at the functional vision, because it is very well related to the cognition. So even if the SNSU doctors are not well equipped to see beyond 1 year, but district early intervention center will be best place to screen for 6 years.
Thank you, Suchandra, yes. And thank you for a wonderful panel. Dr. Naveen, would you like to make the closing remarks? Not sure. Okay, so I think this was so good that we didn't really realize that 2 hours was passed, and we are very thankful to Dr. Anand Vinekar, Dr. Subhadra Jalali, who with your passion, I must say that your passion is infectious. And when we listen to you, we feel that eyes are indeed the most important organ of the body. But it's also important for us to remember that it's all about good neonatal care. And we hope that through these academic sessions, to strengthening our fellowship programs, we are on the road to it. Thank you very much. Thank you, Dr. Rishikesh, Dr. Deepak Chawla. You are leading our guidelines, which is such a big thing for us in India, so that we do good neonatal care. Thank you, Dr.